Peritoneal Dialysis Catheters, Patient Care Plan. There are several different types of peritoneal catheters. All catheters are made of silicone to prevent irritation. Polyurethane catheters are no longer produced. The Tenchkov catheter, seen on the left, was created in the 1960s as a less irritating catheter. It remains in use today as a generic catheter. The Swan-Neck catheter allows for a 150 to 180 degree bend downwards into the rectus muscle. Coil catheters decrease inflow pain. The Toronto Western catheter has a Dacron polyester disc which prevents micration and leaks. All cuffs are made of Dacron. If a double cuff is present, then one cuff is placed in the rectus muscle and the second cuff is placed 2 to 4 centimeters from the exit site. All swan necks are double cuffed. The Swan-Neck Missouri Catheter is also called the Peritoneal Catheter. It is a modification of a lower abdominal catheter allowing for an exit site on the upper chest. Two sections of a catheter are joined together internally in the abdomen with a titanium connector. The catheter itself is made out of silicone with a polyester cuff. As we can see here, the exit site is on the anterior chest side. This is useful in patients who are obese, have incontinence, ostomize, or are likely to bathe in a tub. The rationale for the use of this type of catheter is that there is less movement with the chest wall location than with an abdominal location, therefore increasing healing and allowing for less risk of trauma to the site. Patients that are obese with multiple abdominal folds are able to use this configuration. It is also useful in patients that are incontinent or have ostomies. Patients that like to bathe can use the peritoneal catheters as it usually kept out the water of the bath. There are several advantages as well to using this type of catheter. It can be used in patients that have dexterity problems. It can be cut to size for the patient that allows for peritoneal or upper abdominal exit site. It is also ideal for patients with an active lifestyle. Patients that are also self-conscious of their body image also usually prefer the Swan-Neck Missouri Catheter, as it is more appealing to have an exit site on the chest as opposed to the abdomen. If the patient is sexually active, it will also cause them less discomfort than an abdominal exit site. There are, however, disadvantages. The catheter must be inserted surgically and cannot be inserted laparoscopically. There is also slower flow of the dialysis solution due to the increased length of the tubing. During the pre-insertion preparation phase, nasal cultures are taken, testing for MRSA and treating as necessary. The abdominal wall is also assessed for hernias. After the assessment, the abdominal and chest wall is marked for insertion sites. These sites should be in a position that can be readily accessed by the patient. During the preoperative care phase, the patient should be cleaned with an antimicrobial preoperative skin cleanser. They should be cleansed in the shower for 3 minutes as a scrub prior to surgery, then dried with a clean towel, and they should dress themselves in clean clothing. Distended bowels can interfere with the placement of the catheter. Therefore, patients should have a bowel preparation the night before surgery and should be nothing by mouth the day of insertion. The bladder should be emptied prior to surgery. A Foley catheter may also be inserted depending on hospital policy. It is also very important to clip or shave all hair from the surgical site to decrease post-operative surgical site infections. Prophylactic IV antibiotics, such as generation cephalosporins, are given at the time of catheter insertion to prevent infection. During the post-operative care phase, the primary goal is to prevent growth at the insertion site and trauma at the exit site and tunnel. The dressing should be changed weekly for the first 2 to 3 weeks. The patient should also avoid submerging the site in water during this time to prevent any waterborne pathogens from entering the site. Aseptic technique must be used during dressing changes, including sterile gloves, mask, and sterile dressings. Non-occlusive dressing should also be used to permit the site from draining and drying, rather than pooling at the exit site. The patient is to avoid any activities that increase intra-abdominal pressure, such as coughing, constipation and straining during bowel movements, bending over, and squatting. The catheter also needs to be immobilized at all times to prevent trauma to the device and to the patient. The goal of long-term exit site care is to prevent infections to the site and to continually assess this exit site. The long-term care begins 2 to 3 weeks after the catheter is inserted. The site should be healed at this point. The goal is to assess for signs of pain and/or tenderness, redness, drainage, and crusting. The site is also to be cleaned whenever it is wet or dirty. Proper hand washing techniques should be used at all times when touching the site. The site can be cleansed with an antibacterial soap or a non-toxic antiseptic wash. It should be cleaned with a clean washcloth and towel. However, sterile gauze is not necessary. Occlusive dressings should be placed over the site if the patient will be swimming, and the dressing should be changed immediately afterwards. Complete wound care should be done in a clockwise fashion, starting closest to the catheter and working outwards. It is very important to not remove the scabbed areas. This catheter is very important as it allows the patient to maintain their freedom and live their life at their own pace. Thank you very much for your attention, and make sure to keep your kidneys healthy.